Vitamins and Minerals by Laureano Deficiency and the STEP Disciples. Here are the Step 1 topic lists that we're going to be going through today. It's quite short, but it's going to be a short lecture too. I'll try to make it as interesting as possible, however. I have no relevant disclosures to make. So we'll start then with a definition. The recommended daily allowance, or the RDA, is the amount of substance that is recommended to be taken by a 70 kilogram male per day, or 154 lab if you're going to use, United States units. I'm not gonna, in this lecture, I'm really gonna assume that you know some of the basic things just from your common knowledge, like, how many calories are recommended for a 70 kilogram male per day, around 2200, 2300. I'm gonna assume you know things like that because, this lecture can become very long if I spend time, saying, what's the recommended amount of protein that you should get per day, recommended amount of carbohydrates that you should get per day. Those things you can easily find on almost any, box of cereal. So we're not going to spend time talking about things like that. I think what we're going to go through next is going to be what malnutrition is all about. So malnutrition actually technically refers to both overnutrition and undernutrition. And you can be malnourished in terms of calories. You can be malnourished in terms of vitamins. You can be malnourished in terms of minerals, in terms of protein, carbohydrates, you name it. You can be malnourished in it. Now, typically, under normal, day-to-day conditions, when we speak about malnourished, we really usually are talking about undernourishment. And so what we'll go through next is going to be, you'll see in the next slide. So we'll start then with protein-calorie malnutrition. The big example here is going to be Kwashiorkor. Okay, this is a malnutrition that results from protein malnutrition. It's a condition rather that results from protein malnutrition only. So you have no other malnutrition going on, just a lack of protein. And that results in pronounced edema due to loss of oncotic blood pressure. So if you recall from the cardiovascular system lectures, and you may not have watched them yet, but they are also in our MCAT series of lectures. So assuming you know or remember that if you took our MCAT prep course, that there are proteins that are found in blood that are not found in extracellular fluid space, and that generates then a pressure inward called the oncotic pressure or the osmotic pressure due to the proteins in blood. And well, if you have protein malnutrition, you aren't going to be translating and exocytosing and having those proteins in blood. You're not going to have them there. They're going to be diminished. And so you lose that oncotic pressure inward. And so it turns out then at the capillary beds, you're going to have way more filtration that is occurring than normal, and you're going to overload the lymphatic system. The lymphatic system is not going to be able to take up all that excess filtrate, and you're going to end up with edema. And so I have a little story for you. When I was in high school and I was a complete idiot back then, I used to see these commercials about these children who are starving in these third world countries, and I would think, their belly, they're so swollen, they seem to be doing all right, right? And you see that here. This is one of the trademark symptoms of Kwashiorkor, this distended belly. And I used to think, well, they seem to be eating all right, but it turns out that is due to the edema and the fluid within the GI system now that resulted from that loss of oncotic pressure. It's not due to food. They're not eating. It's also characterized by enlarged fatty liver, but the treatment involves slow rations of hyperglycidic acid every 2 hours or so for about 2 weeks, and then you gradually enrich with proteins and other foods. So it's very dangerous to just immediately give them large rations of food. You actually have to do it very slowly. And that'll be the case for anyone who's been starving for quite some time. The prognosis is good. That is the outlook of the disease, how they're going to progress through the disease. It's good. The prognosis is good if it's caught in a reasonable amount of time, although damage can be irreversible depending on the time of development. So it's important to remember that, development is a very precarious period. I mean, if you are missing ligands and signals that would normally generate a response that would lead to then the formation of some tissue, or some organ, if you're missing the ligand, if you're missing the building blocks you need to build that tissue, you may not build that tissue, or you may build that tissue inappropriately. Right, critical period of development, and so it's very important to be well nourished, especially during development. We'll move on then from Kwashiorkor, which is that protein malnutrition, and to another type of malnutrition, which is Marasmus. So this is actually a protein and calorie nutrition. It's just general malnutrition. And as you can imagine, nothing works well. I mean, if you're not providing yourself lipids and nucleic acids and amino acids to make protein, to synthesize DNA and RNA, nothing really is going to work well. The treatment involves slow ration of the food, gradually increasing over time. All right, and again, just like the last slide, the prognosis is typically good if it's for a short period of time, but if you extend that for a long period of time, the damage can be irreversible depending on the time of development. So those are our big players for malnutrition. So then we'll, in terms of calorie and just nutrients in general, so we'll move on then to talk about vitamins. So vitamins are a general classification of compounds that we need for survival and that we cannot synthesize. So that's what vitamins classically are. And so there are and here it is. Vitamins are a group of structurally and functionally unrelated compounds that cannot be synthesized and hence are required in our diet. And I put a little star there because some of the vitamins can actually be synthesized, but sometimes they're not synthesized at a high enough rate that we can get enough for the day, for example. The big example of that is vitamin D. So here's the list of the water-soluble and the fat-soluble vitamins. We break them up that way because there are characteristics of fat-soluble vitamins that are not characteristic of water-soluble vitamins. And I'll break this point to you now. It's the fat-soluble vitamins that can really last a very long time in our body. And that's because they are fat-soluble. They can get out of blood and find themselves in, let's say, adipose tissue or liver tissue and spend some large amounts of time there. And the reason for that, and the reason why their half-life is so large, and again, the half-life is the amount of time it takes for a compound to reach half its initial concentration. The reason why the fat-soluble vitamins have such a high half-life is that the kidney functions by filtering everything and then repicking up what it needs to pick up. Well, when the kidney filters the vitamins, it typically won't pick up any vitamins. So any vitamins that find themselves within blood, which is the water-soluble vitamins for the most part, they're going to get filtered and they're not going to get retaken up at the collecting duct. And guess what? You're going to urinate it out. So that's why. Anyway, we're going to start with the fat-soluble vitamins. So I have a little mnemonic. It's just called ADEK, A-D-E-K. I don't know why. That's just memorable to me as the fat-soluble vitamins. So we'll start there, and then we'll go with the water-soluble vitamins after. So fat-soluble vitamins. So we'll start then with vitamin A. So the deficiency associated, when you have a vitamin A deficiency, what results is vision problems. So the carotenoids or the beta-carotenoids and the retinoids are collectively known as vitamin A, and they're keenly important for vision. So it turns out that they're the protein, it's called a rhodopsin protein, that is involved in the phototransduction pathway within the retina, and it has a retinoid within it, it's called 7-retinal, that undergo the conformational change from a cis conformation to a trans conformation under the presence of light. Right, so light will initiate the conformational change from cis to trans, and that'll initiate a second messenger signaling pathway that ultimately leads to the activation of neurons that ultimately lead to the occipital lobe, and vision occurs. Right, you see something. And when you have that deficiency, then you can't do that. So I think it's worth going through the structure of the eye because you have to know it. It's always good to review if you don't know it. So you have on the outermost portion of the eye, you have the cornea. Then you have the aqueous chamber, which contains then the aqueous humor. It's just it's a fluid, and under that then you're going to have the pupil, right? And then you're going to have the lens, and the colored portion of your eye is actually called the iris, okay? And the lens will then be suspended by the suspensory ligaments, and then the ciliary bodies will be binding to these suspensory ligaments, and these ciliary bodies can contract and change then the width of the lens and change then where the light lands on the retina. So the retina is actually the back portion of the eye and contains then the rods and cone cells that will depolarize and synapse onto ganglion cells, which would then ultimately synapse onto, but actually coalesce to form then the optic nerve. And then that would go through the optic chiasm and go through the optic tracts, ultimately go to the lateral geniculate nucleus of the thalamus, do radiations to the parietal and temporal lobe, then ultimately go to the occipital lobe. I skipped a few things here that I really want to discuss. Actually, I'll get there in a second. So again, the deficiency is vision problems associated with vitamin A, which is again the retinoid, the beta carotenoid, and the carotenoids. And one of the diseases that result, or the problems, the conditions, is xerophthalmia. So it's a medical condition in which the eye fails to produce tears. That is just, another way of saying fluid. And results in dryness and tearing of the cornea, and then blindness. So why did that produce blindness? Well, and let me define one more thing. The conjunctiva, the stratified conjunctiva, I'm sorry, can't pronounce things today. Conjunctiva, the stratified columnar epithelium with goblet-celled lining sclera, or the white of the eye. So the sclera is actually the white of the eye, and I didn't define that here, but this is the white of the eye, right? And they're the stratified columnar layer on top of the sclera, and that's what's producing the tears, right? That's what's moisturizing your eye. The goblet cells secreting mucus. And a deficiency actually results in the failure to produce eyes. We won't discuss why that is, just appreciate that that is the case. But why would that produce blindness? Well, if you don't produce the tears, right, then your eye won't be moisturized, and that would produce friction that would ultimately tear the cornea. So it turns out, and if you watch my optics lecture, you would know this, that the cornea is the major bender of light. It actually isn't the lens. The lens actually bends light very little. And so the cornea is really what does the major bending of the light that comes in from the outer world and into ultimately to the retina. And so if you don't get that bending of light, you're not going to be able to focus light onto the retina. You will not be able to perceive images. Well, perceive is a bad word. You won't be able to get that initial stimuli. You'll get blindness. The other thing that results is follicular hyperkeratosis. So it's skin and hair follicle changes due to increasing keratin production. Again, it just turns out that the molecule that result from these vitamin A precursors are involved in keratin production. It probably functions as a cofactor of sorts in keratin production. And so one of the other things that you'll see in somebody who's vitamin A deficient is called Bitot spots. It's just clumps of keratin in conjunctiva cells. And when I say clumps of keratin in conjunctiva cells, I literally mean within the cell cytoplasm there'll be chunks of keratin. So the treatment, again, just eat some vitamin A rich foods like carrots. We'll move on then from vitamin A to vitamin D. So vitamin D deficiency, you have bone problems. Again, many of these, particularly the vitamin D and some of the minerals that we're going to go through today, we're going to go through in more detail when we cover the physiology behind where they play their most significant roles. So this I won't spend too much time on vitamin D. You probably know it already. Vitamin D can be synthesized via the skin, but some people don't get enough light, so it is considered a vitamin. So here is the endogenous pathway to produce vitamin D, ultimately produce vitamin D3. So it turns out that UV light rays can actually convert a cholesterol derivative, 7-dehydrocholesterol, into vitamin D3, which is cholecalciferol. That can undergo a conversion in the liver, and then another conversion in the kidney to ultimately form then the active hormone, which is 1,25-dihydroxycholecalciferol, or calcitriol. That has a number of functions here, which most of them probably don't make sense to you, but the one that probably does make sense is this calcium-stimulated ATPase that increases the expression of this calcium-stimulated ATPase that ultimately increases intestinal absorption of calcium. That increases plasma calcium concentration. So the function of vitamin D is to increase plasma calcium concentration. And in fact, the way in which the parathyroid hormone actually increases the absorption of calcium in the intestine is actually through increasing the synthesis of this compound calcitriol, which is a derivative of vitamin D. And again, we can, instead of making this through the endogenous pathway, we can just eat vitamin D, and it'd probably meet up somewhere around here to ultimately exert these effects of the hormone. Right. So deficiency leads to things like rickets, osteomalacia, and osteomalacia, another way to say that is just adult rickets and hypocalcemia. As you know, if you don't have vitamin D, plasma calcium levels are just going to drop. And if calcium levels drop, you're not going to get enough bone formation, right? Calcification of the collagen. And if you don't get enough calcification of the collagen and, the osteocytes and what have you, guess what? You're going to have weak bones. You're probably going to be bow-legged, that kind of thing. and hypocalcemia. So it turns out that in hypocalcemia, as well as the converse, which is hypercalcemia, the result is going to be opposite of what you would calculate with the Nernst equation. So in hypocalcemia, typically with the Nernst equation, you would expect that you would get a hyperpolarization, but it turns out that you actually get a depolarization. And that is simply because calcium actually functions, well, calcium can actually block cation channels, and it just so happens that it'll block a voltage-gated sodium channel that'll make it more difficult to excite tissue. All right, overdose. If you overdose on vitamin D, this is the kind of things you can get: hypercalcemia and calcification of heart vessels and nephrons. That's just a mass action effect, really. You increase vitamin D, you will increase calcium, extracellular fluid-space calcium levels, and you'll get calcification. And again, hypercalcemia, you would expect it via the Nernst equation to actually cause depolarization, but it actually causes hyperpolarization because all of that calcium can block those sodium channels, those voltage-gated sodium channels, and when you do that, guess what? You block voltage-gated sodium channels, you're going to hyperpolarize, right? It's going to be more difficult to get excitation. So we'll move on then from vitamin D to vitamin E. So vitamin E deficiency is associated with an anemia. So vitamin E refers to 8 relatively structurally unrelated compounds that mainly function as antioxidants. So what all that means is that it pick up free radicals in the body. Deficiency is associated with hemolytic anemia due to oxidative damage to red blood cells, vision problems, and nervous tissue malfunction. You can imagine that if you have less antioxidants running in blood, okay, you're going to have more free radicals running around in blood. And these free radicals can come from a number of places. Typically, it comes from leakage from the mitochondrial electron transport chain, but the leakage can also come from phagocytic cells releasing reactive nitrogen species and reactive oxygen species from their phagolysosomes. Either way, wherever it comes from, if you have less antioxidants, you're going to have more hemolysis of red blood cells, right? Because you can get that initiation, propagation, termination, reaction mechanism, and that ultimately destroy tissue. All the other things are ramifications of that. This deficiency is very rare. It's either in newborn, those with abnormal fat metabolism, or fat absorption, right? Again, these are the fat soluble vitamins. So one of the big ways that you can get a deficiency in a first world country in vitamins is if you have some problem with your digestive system where you're not absorbing or you're not being able to metabolize some nutrient. That's one of the big ways. As us, relevant to us is going to be that kind of situation, right? Maybe you have Crohn's disease or whatever. Treatment would be vitamin E supplementation, so extra virgin olive oil, for example, or sunflower oils. Then we come to vitamin K. So my mnemonic here is vitamin K deficiency is associated with coagulation problems. So you just change the C to a K like I did up here and you're golden. So vitamin K is actually required for the synthesis of many clotting factors, including prothrombin. So you may or may not be familiar with this. If you've watched my immunology lecture, then you are. Turned out that at the end of a cascade of proteases, prothrombin requires factor X to be converted into thrombin. Thrombin can convert fibrinogen into fibrin, and then fibrin, along with platelets, can form then a good clot within a ruptured blood vessel. And well, if you don't have any prothrombin, then you're not getting any thrombin, you're not getting these downstream events, you're not getting clotting. So deficiency would be hemorrhagic disease. So hemorrhage is severe loss in blood volume, so typically 20% would be defined as hemorrhage. And so when you have hemorrhagic disease, you're losing a lot of blood, and you're losing a lot of blood because once the blood vessel ruptures, you can't clot it up, you can't stop the blood from being lost into the extracellular fluid space. Again, it's rare. Vitamin K is actually also made by the gut flora, so prolonged antibiotics may cause this deficiency. This is particularly relevant for people who have been hospitalized for long periods of time and have been taking antibiotics during that time. Treatment would be vitamin K supplementation, so leafy greens, fish oil, and meats, for example. So this is just a little video of a clot formation, a little red blood cells running. You got some platelets flowing in blood. They recognize the collagen, so it's in fact the case that the platelets actually have receptors that can bind to free collagen, and that's what makes them sticky, if you ever heard that terminology, which you have in my immunology lecture. So more platelets come along, factor X will come along, convert prothrombin into thrombin, and then fibrinogen into fibrin via thrombin, and then you get this cross-linked fibrin clot, very stable clot. Well, again, if you don't have prothrombin, you're in big trouble. There are overdose toxicity associated with the fat-soluble vitamins. I'm not really going to make a big stink about this because I don't think it's that important, but I'm just going to say them now, and that's all I'm ever going to say about them. Vitamin A, if you overdose on it, you can have congenital malformation in developing fetus, increase intracranial pressure, liver toxicity, bone pain, fatigue, and skin changes, and alopecia, so losing hair. Vitamin D is hypercalcemia, calcification of heart vessels and nephrons. If you overdose on it, we've already gone through that. That's important for you to know. Vitamin E is decreased synthesis of vitamin K, very interestingly, which also may lead to hemorrhage. That's something interesting. Vitamin K is unlikely to be toxic in adults, but in children and newborns, you might have hemolytic anemia and jaundice in newborns if mother receives excess vitamin K. So those are the overdoses associated with it, but this is very rare, right? I think the only way you'd see this if somebody's taking too many vitamin pills. Fat-soluble vitamins are much more likely to reach toxic levels since they can be more easily stored in tissue, particularly adipose tissue. So again, you're only really going to see this though if somebody's taking pills and they're taking way too many. That was the fat-soluble vitamins. Again, ADEC, vitamin A is retinol or beta-carotene. They're carotenoids. Vitamin D is cholecalciferol. Vitamin E is tocopherol. Then vitamin K is just vitamin K, right? It's a group of many different compounds that functionally function to coagulate and function in the synthesis of coagulation factors. We'll take it then to water-soluble vitamins. Start off with vitamin C. So the deficiency associated with vitamin C is scurvy. So vitamin C or ascorbic acid play the critical role in hydroxylation events that occur in the synthesis of collagen. So remember, collagen is a three peptide repeat. So it's usually hydroxyproline, lysine, and then some amino acid. But typically proline, lysine, some amino acid, right? And that'll repeat. That structure will repeat, and then it'll form then a coiled coil, and then it'll come together to form filaments. Turned out that vitamin C played the critical role in the crossing events that occur between the collagen protofilaments to form the collagen filament. And well, if you don't have vitamin C, you won't get the hydroxylation events. If you don't have the hydroxylation events, you can't form the crossings. You get scurvy. So scurvy is characterized by bleeding, easy bruising, and scorbutic gums, if you would, because collagen is what gives most tissues their strength and rigidity. And so, what surrounds blood vessels? What's the structure of blood vessels? Actually, let's pause on that. I'm gonna get to that next slide. What are the other things that you might be able to associate with this? If you don't have collagen, what's bone made out of, right? Collagen. There's a lot of collagen. And so you can imagine they will also have weak bones and may have bowed legs as well in this scurvy condition. But again, easy bruising. Well, actually, we're gonna get to that next slide. Ooh. So treatment: eat vitamin C rich foods, oranges, lemons, limes, etc. So I'm gonna talk about what I was trying to get at later. So recall the layer of the blood vessels. Okay, you have the tunica intima, the tunica media, and tunica adventitia. In the tunica intima, you have the layer of simple squamous cells and endothelial cells. Okay, a thin layer of connective tissue. In the tunica media, you have smooth muscle, and then you have collagen, elastic fibers. Okay, connective tissue. And then tunica adventitia, you also have connective tissue. In all those layers, there is collagen. So loss of collagen due to vitamin C deficiency will cause the easy bruising. So what bruising is the rupturing of blood vessels near the skin. What gives blood vessels their rigidity is going to be the connective tissue, particularly the collagen in the connective tissue, as well as the elastin is what's going to give a tissue its rigidity as well as its elasticity, right? And so if you're missing one of those components, you're going to be in big trouble, and what you're missing in vitamin C deficiency is just that, collagen. We'll move on then to vitamin B1 deficiency. So associated with that is going to be beriberi. So vitamin B1 or thiamine serves as a precursor to the thiamine pyrophosphate, TPP, which is the cofactor required for many enzymes in the TCA cycle and the pentose phosphate shunt. And without it, it must run the glycolytic cycle for ATP, which is inefficient, right? So if you remember from my citric acid cycle lecture way back when, in when you're studying for the MCAT, or if you watched it, for the step already. You recall that I have that mnemonic, pyruvate T dehydrogenase, alpha ketoglutarate dehydrogenase. Those reactions were reactions that require the use of the E1, E2, E3 reaction mechanism, and the first portion, E1, actually uses thiamine pyrophosphate to make an alpha keto acid think it's a beta keto acid and calls for a spontaneous decarboxylation. Well, TPP obviously comes from, as we said, vitamin B1 or thiamines, hence the name thiamine pyrophosphate. And so if you don't have those puppies working for you, you can't run the TCA cycle because the TCA cycle requires that. So you'll be stuck then running the glycolytic cycle, because the glycolytic cycle does not require the use of TPP. Deficiency manifestations include dry beriberi, which is impairment of the nervous system due to myelin sheath degeneration. Not really clear why that is. But that myelin sheath degeneration, called the Wernicke encephalopathy, so just a general name, encephalopathy, brain damage, is a type of reversible delirium. You have encephalopathy, ataxic gait, or irregular posture and movements, and some type of oculomotor dysfunction. The thing that differentiates really Wernicke encephalopathy and Wernicke-Korsakoff syndrome is that it's a type of irreversible dementia, Wernicke's-Korsakoff syndrome. So it's irreversible. But both are associated with confabulation and retrograde and anterograde amnesia. So what confabulation is, making up memories that didn't really happen. That's what confabulation is. Retrograde and anterograde amnesia is, I think, relatively straightforward what that means. And then you can also have wet beriberi. So when you say the term wet beriberi, all you mean is that the cardiovascular system is involved as well. And what happens is that systemic vasodilation leads to overworking the heart to maintain blood pressure and ultimately heart failure. And I will go through that on the next slide, but it's not really clear to me, at least, and I don't think it's clear to anyone, what causes this systemic vasodilation, but it just is the case that when you don't have thiamine, you have this systemic vasodilation that occurs in some cases that develop into wet beriberi. So again, the treatment is vitamin B1 supplementation, but your recovery is very unlikely once you reach that Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is also associated with alcoholism, because it turns out that alcohol inhibits the uptake of vitamin B1 or thiamine in metabolism, so the uptake from the GI tract. Anyway, wet beriberi, I just want to talk more about it. For some reason, you get systemic-wide vasodilation, and that leads to increased cardiac output plus salt and fluid retention to compensate for the decreased resistance that we lost, right? Vasodilate, decreased resistance. So in order to get blood pressure up towards normal, we're going to have to increase cardiac output. That's going to be mediated through the baroreceptor reflex. You're also going to, right, so and how we increase cardiac output is we increase heart rate and increase stroke volume. We increase the sympathetic output and decrease the parasympathetic output. We increase salt and fluid retention via the renin-angiotensin-aldosterone system. I'm not going to go into the details here on that. All that functions to do is increase R towards normal, but now you have an increased resistance and a heart working harder and harder to pump against this higher resistance. So ultimately, you're going to get edema and heart failure. The reason why you're going to get edema is because you're increasing cardiac output, you're increasing salt and fluid retention. You're going to increase the amount of fluid within the vasculature, and then once you get to the capillary beds, there's not going to be a loss of oncotic pressure, and there's going to be more hydrostatic pressure. So you're going to end up getting then a net filtration effect, a greater net filtration effect that's going to result in edema and heart failure. Heart failure because the heart's working against a higher pressure. Ultimately, you're going to get some infarction, probably due to hypertrophy of the left ventricle. Anyway, let's move on from vitamin B1. So vitamin B1 was thiamine, right? Formed of thiamine pyrophosphate associated with beriberi and wet beriberi. So beriberi is associated with the nervous system and degeneration of the myelin sheath, and wet beriberi is associated with involvement of the cardiovascular system that ultimately leads to heart failure if left untreated. Move on then to vitamin B2 deficiency, or inflammation of the mouth and throat. That's what the deficiency is associated with. So vitamin B2, or riboflavin, forms the flavin compound, flavin mononucleotide and flavin adenine dinucleotide. I probably should have put what those meant, but these puppies, FMN and FAD, would serve as electron carrier molecules in, for example, electron transport chain. Complex, you can find flavin mononucleotide in complex 1, and you can find flavin adenine dinucleotide in complex 2, as you probably recall from the electron transport chain lectures, as well in beta oxidation. You can find the FAD compound. They're electron carriers, and they're obviously important if they're working in the electron transport chain. You know that's part of cellular respiration. That's how we make ATP. The pure deficiency of the flavins are actually rare, the riboflavins, so vitamin B2. It's typically found in foods that are also filled with other B vitamins. So pure deficiency is rare, but if you do have a pure deficiency, it's associated with inflammation and cracking of the mouth, lips, and pharynx area. That's probably very hard to differentiate from, an actual infection. Anyway, the treatment is vitamin B2 supplementation. That's vitamin B2. That's the riboflavin that gives rise to the flavin compounds, which serve as electron carrier molecule. Move on then to vitamin B3 deficiency. So the deficiency associated with vitamin B3 is Pellagra, which is just, classically, rough skin. Anyway, vitamin B3 or niacin or nicotinic acid form the nicotinamide compounds, nicotinamide adenine dinucleotide and nicotinamide adenine dinucleotide phosphate, which serve as electron carrier molecules in a number of metabolic reactions, such as cellular respiration, that's NAD, and the pentose phosphate shunt, NADP+. These are, you probably already know what these are if you watch my lectures. Otherwise, you probably just know that they function as electron carrier molecules. I'm not going to go into the details. Deficiency associated with Pellagra, rough, painful skin. So you can note the rough skin in this image here to the right. So it turned out that Pellagra actually required the protein deficiency as well, because tryptophan, which is an essential amino acid, can be converted to niacin. But knowing that it's an essential amino acid, you know that you actually have to intake that amino acid in your diet because you can't synthesize it. And so if you're not taking in enough tryptophan and you're not taking enough vitamin B3, then you'll result in Pellagra. But otherwise, you won't. So there's actually the 4D, the deficiency associated with Pellagra. It's associated with vitamin D3 deficiency, rather. It's diarrhea, dermatitis, dementia, and death. Death is actually in 4 to 5 years if left untreated. So as you know, you see nicotinamide adenine dinucleotide in a number of reactions, like glycolysis, right? You see it in citric acid cycle, and then you see it giving up proton in the electron transport chain to generate that proton motive force that's ultimately going to allow for the dissipation of the proton gradient to form ATP, and that's all critical to our success and our survival. So yeah, you're gonna wanna get some niacin in you. Treatment is treatment is B3 okay, all the treatments are gonna be supplementation, right? Let's not be foolish. What's important for you to know is kind of the sources, which is meats and processed foods. Move on from vitamin B3, which is known as niacin, and move on to vitamin B5, which is pantothenic acid. So it turns out that pantothenic acid is required to synthesize coenzyme A or CoA, a molecule attached to many compounds in metabolism, for example, acetyl-CoA, or you can also call that acetyl-coenzyme A or acyl-CoA, one of the ways that you charge fatty acids to go through beta oxidation. Deficiency is very non-specific, and deficiency also overlap for B vitamins, so we really don't have much to say here. And I'm not showing an image of pantothenic acid. It's a very long, large compound. But deficiency symptoms are headache, fatigue, and impaired muscle coordination. Treatment is B5 supplementation. It's actually found in almost every food, and that's why the deficiency symptoms overlap with so many other B vitamins. We'll move on then from vitamin B5, which was known as pantothenic acid, and move on to vitamin B6, which is associated with hyperhomocysteinurea. It also turned out that vitamin B9 and vitamin B12 are also associated with hyperhomocysteinurea in their deficiency states. Vitamin B6 is a family of 3 compounds, pyridoxine, pyridoxal, and pyridoxamine, that all can be converted into pyridoxal phosphate, or PLP, compound required for transamination reactions between amino acids and keto acids. I briefly mentioned PLP when we talked about enzymes and enzyme kinetics. I gave you an example of PLP that catalyzes transaminase reactions, and believe I said that the transaminase reactions are examples of reactions that occur with synthesis. Anyway, this is the reaction scheme here, not really important to go through in this context. You should appreciate, though, that vitamin B6 is required for the breakdown of homocysteine into cysteine and hemoglobin synthesis, and that gives us and tells us the relevant pathology just based on that. So deficiency leads to hyperhomocysteinurea. We'll go through that in a few slides. It's also important to appreciate that all amino acids become essential in the deficiency state, because the way in which the function of PLP is to do these transamination reactions, to actually interconvert amino acids from one another and interconvert amino acids from alpha keto acids. And so if you do not have that function working for you, for example, you can't convert alanine into glutamate, you can't convert alpha ketoglutarate into you can't convert alpha ketoglutarate into glutamate, and you can't convert alanine into pyruvate. If you don't have that reaction working for you, all the amino acids are going to become essential, because the way in which we get some of the amino acids is in fact through this PLP transaminase reactions, and PLP is a huge cofactor in those transaminase reactions. So all amino acids become essential in deficiency state. And deficiency also causes anemia, convulsion, the peripheral neuropathy. Again, if it's required for hemoglobin synthesis, then of course, anemia, just the general statement, anemia is just a situation in which you either don't have enough red blood cells, or you don't have enough hemoglobin, or you don't have something that leads to having low oxygen deprivation, right? Not being able to carry enough oxygen. So, again, treatment is B6 supplementation. I just kind of want to walk through this figure here. Here's homocysteine here, and turns out that vitamin B6 is required to break it down into that. And if you don't have that working for you, then guess what? You're going to have hyperhomocysteinurea, and then ultimately leads to neural tube defects, so spina bifida. And we'll talk about that later. We'll move on then from vitamin B6 and move on to then, and again, vitamin B6 is those pyridoxal compounds that lead to the formation of pyridoxal phosphate, and that's important in transaminase reactions. And we'll move on from that to vitamin B7 deficiency, which is associated with skin problems. So biotin, I'm sure you've heard about biotin. It's a very hot topic, especially for men and women who want to grow their hair. So vitamin B7 or biotin is important for the proper synthesis of hair and nails, and play the critical role in carboxylation reactions. It actually may help with hair growth, if you take excess amounts of what's recommended. It's been shown in studies to increase hair growth in women whose hair was thinning. And I mean, that makes sense, right? It's important for the proper synthesis of hair and nails. Don't really want to go into why. Deficiency is pretty obvious based on what I just told you. Dermatitis, right? So inflammation of the dermis of the skin. Alopecia, or hair loss, and enteritis. I guess the enteritis doesn't really make much sense. It's important to remember that biotin is a critical cofactor in carboxylation reactions, particularly important in the gluconeogenic response. Raw egg consumption may cause deficiency. So it turns out that there's a protein in raw eggs called avidin that will actually bind to biotin and prevent then the absorption of biotin from the GI tract. And obviously then that may cause a deficiency. Treatment, eat some fish or some meat. Move on from vitamin B7, which is known as biotin, important for growth of hair and nails, and move on to vitamin B9, which is the folate. So vitamin B9 or folate is the precursor to a very important coenzyme in purine and pyrimidine synthesis and amino acid breakdown. It leads to the formation of tetrahydrofolate. So it turns out that, I guess it does turn out that purine and pyrimidine synthesis is required for growth and development of all cells. You know that. You know that. Because you know those are what ultimately will make up deoxyribonucleic acid or DNA. And well, if you don't have the bases that make up DNA, you're not making DNA, and if you can't make DNA, you can't grow, you really can't divide. So you can't develop. And deficiency then would be associated with hyperhomocysteinurea, as I suppose. I did tell you briefly that it's involved in amino acid breakdown synthesis, and here's homocysteine, here where the folate is playing its role. And well, if you don't have the folate, then obviously it's going to be a problem then you're going to get homocysteinurea. And if you get homocysteinurea, hyperhomocysteinurea rather, so cysteine in blood and in urine, you'll get spina bifida in the fetus. So, and it's actually critical in the first 28 days after conception to prevent this. You need to have enough levels of folate. And so really, it's almost a lot of women, after they find out they're pregnant, they'll start to take folates, but you were supposed to take those before you were planning on getting pregnant. Deficiency, also called the megaloblastic anemia, because cells grow but they're not able to divide. Remember, there are checkpoints in DNA in mitosis, right? In fact, when you're going in the second growth phase, it'll actually check to see if the DNA has been replicated. And well, if the DNA has been replicated, you're not going to divide. It'll still grow, but it won't get past that D2 phase, because one of the checkpoints is to make sure that you have 2 complements of DNA. And if you don't have that, well, you're not going to divide. You're just going to be one big old cell that grew but didn't divide. And so that's how you get megaloblastic anemia. Methotrexate is a cancer drug that inhibits the formation of THF, and that causes deficiency symptoms. And deficiency can be quite common in pregnant women. Again, just happens to be the case. And really, the reason why it becomes a deficiency is because they're taking care of two human beings. And the treatment is benign supplementation, so spinach, kale, collard greens, and other leafy greens. Folates, leafy greens. Leafy greens, folates. Okay. Why don't we talk about hyperhomocysteinurea a little bit more? So here's spina bifida. So spina bifida is just a neural cord defect where the neural cord is actually open, and the spinal cord can actually get out of the vertebral canal and find itself being pinched by some of these processes and just open, really. And they have different classifications depending on whether or not the spinal cord is actually out of the vertebral canal or not. Hyperhomocysteinurea called spina bifida again. And here are all the vitamins involved in the breakdown of homocysteine. And again, you could prevent by having mother ingest proper level of B vitamins, before, 28 days, within 28 days, so beginning of conception and then 28 days after, you want to have her on enough folates. So we'll move on then from vitamin B9, which is associated with folates, and finally, the last one we're going to talk about for today is vitamin B12, which is the cobalamins. So deficiency is associated with megaloblastic anemia and nerve degeneration. So vitamin B12 is a collection of cobalt-containing compounds called cobalamins. Remember cobalt from that good old periodic table? These are required for homocysteine metabolism as well as required to isomerize methylmalonyl-CoA, a compound produced in the oxidation of odd-chain fatty acids. So deficiency. You already know it's involved in the breakdown of homocysteine, so if you have low levels of vitamin B12, you're going to get hyperhomocysteinurea. You already know that. And that should say hyperhomocysteinurea, not homocysteinurea. It also results in megaloblastic anemia due to secondary deficiency in folate due to insufficient vitamin B12. So I'm going to make this apparent to you in the next slide. But why don't we just leave it at that for now. And again, megaloblastic anemia, the type of pernicious anemia. So what a pernicious anemia is, it's a type of anemia that results from a lack of B12. Turns out that people typically who have pernicious anemia will have it not because they're not taking enough B12 in, but actually because they have lacking this protein called intrinsic factor that is required for the uptake of vitamin B12 from the GI tract. The other abnormality that results from vitamin B12 deficiency is going to be neurological abnormality, and that's due to the abnormal myelin sheath. So it turns out that one of the things that vitamin B12 is required for is to isomerize methylmalonyl-CoA, a compound that is produced in the oxidation of odd-chain fatty acids. As you know, odd-chain fatty acids don't go through the normal beta oxidation pathway. Well, they do up until a point. And then once you get to propionyl-CoA level, you have to go through a different pathway. And you know that the myelin sheath is just a set of Schwann cells that are mostly phospholipid bilayer. And so when you start to change their phospholipid bilayer because you're not able to oxidize odd-chain fatty acids, you can get abnormal myelin. I don't have much to say about that except for the fact that neurological abnormalities result from a lack of vitamin B12. Treatment is eating meat, shellfish, poultry, and other dairy products. I just want to talk more about, in the next slide, the notion of masking symptoms. So a person's megaloblastic symptoms with B12 deficiency, so these big red blood cells, can be masked via folate supplementation, but it won't fix the nerve degeneration, so it must be caught early or else it may be fatal. So here we have the exogenous folate, and you can see that folate goes through a number of changes throughout its time in the body, and it turns out that vitamin B12 is required to convert folate from this form to this form, and this is the form that is active and is play the big role in doing the cellular processes that it normally does. So nucleic acid synthesis, for example. And when you can't get to that level, to this level, via the lack of vitamin B12 to convert that folate that you had back into a compound that can act in the role that it wants to act in, you're going to get that megaloblastic anemia. You're not going to be able to do nucleic acid synthesis. You're not going to be able to divide. So cells are going to grow but not divide. Well, if you administer exogenous folate, you can bypass this vitamin B12 reaction. And when you do that, then you can mask the symptoms of the megaloblastic anemia, but you won't fix the nerve degeneration, so it can be fatal, right? So don't fall into that trap of treating somebody with vitamin B12 deficiency with vitamin B9 and saying, oh, he got better. You did a histological section, you said no more megaloblastic anemia. Well, you have to check the neurons too, right? Okay. Again, I'm going to go through this rather quickly. So here are the overdoses associated with water-soluble vitamins. So B1, B3, B6, and vitamin C. Thiamine. That's the guy who formed that thiamine pyrophosphate, and high doses can cause heart dysrhythmia and convulsions. Vitamin B3, that's niacin. That's and again, niacin that forms those nicotinamide compounds. So nicotinamide adenine dinucleotide, nicotinamide adenine dinucleotide phosphate. What the overdose is associated with acute flushing. Acute is going to be flushing, itching, and headache. So flushing, red flushing, like the skin. Chronic is going to be jaundice due to liver toxicity. Vitamin B6 are the pyridoxal compounds, ultimately form PLP or pyridoxal phosphate, which is important in transaminase reactions. Overdose of that causes numbness of hands and feet and partial paralysis. Vitamin C or ascorbic acid, and again associated with that, vitamin C is going to be the synthesis of collagen. Overdose is going to be nausea, intestinal cramping, diarrhea, and can result from high intake due to vitamin not being absorbed. And high doses associated with kidney stones. And just because I'm here mentioning this, high doses of vitamin C have not been shown to be effective in preventing common cold. Overdose is unlikely for water-soluble vitamins, since most, again, being water-soluble, are filtered out at the kidneys. Again, how the kidneys work is that they filter everything and reuptake what they're going to reuptake. And we don't really have transporters. And if we do, they're not very good at reuptaking the water-soluble vitamins. Why don't I summarize? Vitamins are a group of structured and functionally unrelated compounds that cannot be synthesized and hence are required. The dietary reference intakes, or DRI, they're set by the FDA and do exactly what they say they do. They set a standard to take every single day for a 70 kilogram male. The fat soluble vitamins are ADEC, right? A, D, E, and K. So vitamin A or retinol are the carotenoids, the beta carotenes, and the retinoids. And deficiency leads to vision problems, right? So we talked about exerophthalmia, where what happens is that the conjunctiva cells fail to secrete mucus, and then you get friction, and you rupture the sclera of the eye, and rather the corneum of the eye, and you get blindness because the big function of the corneum was actually to bend light. The other thing that you get is going to be the excess production of keratin. Vitamin D is cholecalciferol, a conditional essential vitamin that truly is a hormone that functions to increase plasma calcium levels. Deficiency, called as rickets in children, osteomalacia in adults, as well as hypercalcemia. Remember, the active form of vitamin D is going to be that vitamin D3 derivative, which is going to be 1,25-dihydroxycholecalciferol, or calcitriol. That's the other name for it. Vitamin E is a group of compounds that primarily function as antioxidants, and deficiency leads to hemolytic anemia from red blood cell inability to effectively defend against oxidative damage. Vitamin K is required for synthesis of coagulation factors, including prothrombin. Hence, deficiency leads to hemorrhagic disease via failure to clot. The water-soluble vitamins are C and the B vitamins. So, vitamin C, or ascorbic acid, is critical in the formation of collagen. Hence, deficiency leads to scurvy, easy bruising, bleeding, bow-leggedness, etc. All that is just a result of not having collagen, and you know collagen plays a major role in the tunica media, the blood vessels, and so hence you rupture the blood vessels, which is what bruising is. Those superficial vessels of the skin being ruptured, get bruising, get bow-legged because bone is made up largely of calcium and collagen matrix, the organic matrix. So collagen and other glycosaminoglycans and what have you. Anyway, vitamin B1, thiamine, is a precursor for thiamine pyrophosphate, TPP, which is utilized in the E1, E2 reaction mechanisms as well as the pentose phosphate shunt transketolase. Deficiency lead to Beriberi and Wernicke-Korsakoff syndrome. So dry Beriberi just had that neurological involvement, and wet Beriberi involved the cardiovascular system. Typically will lead to heart failure if left untreated. Wernicke-Korsakoff syndrome, again, is that syndrome where you have confabulation and anterograde and retrograde amnesia, and it's a type of irreversible dementia. And it's also associated with alcoholism, right? So vitamin B2, or riboflavin, is a precursor for the flavin compounds FMN and FAD, and electron carrier compound, and they are electron carrier compounds found within the electron transport chain as well as in beta oxidation. Deficiencies are rare but leads to inflammation of the mouth and throat. Vitamin B3, or niacin, is a precursor to the nicotinamide compounds NAD+ or NADP+, which serve as electron carriers in metabolic pathways, and deficiency results in pellagra, rough, painful skin. There's the 4Ds associated with deficiency: diarrhea, dermatitis, dementia, and death. B3, 4D is a little mnemonic for you. Vitamin B5, or pantothenic acid, is required to synthesize coenzyme A, and deficiency symptoms are non-specific, but essentially are headache and fatigue. Vitamin B6 is pyridoxine, pyridoxal, and pyridoxamine. It's a group of compounds that all serve as precursors to pyridoxal phosphate, or PLP, of whom is involved in amino acid interconversion and breakdown. Deficiency leads to hyperhomocysteinurea, anemia, convulsion, and peripheral neuropathy. And it's also important to know and remember that a loss of vitamin B6 or PLP will make all amino acids essential. You will no longer be able to synthesize amino acids on your own. Vitamin B7, or biotin, acts as the cofactor for carboxylation reaction and is important for the growth of hair and nails. Deficiency leads to dermatitis, alopecia, and hair loss. Vitamin B9, folate, is a precursor to tetrahydrofolate, which is a cofactor in purine and pyrimidine biosynthesis, which deficiency leads to hyperhomocysteinurea and megaloblastic anemia, a type of pernicious anemia. And I guess it's probably not completely accurate to call it a type of pernicious anemia. I guess a better way to say that megaloblastic anemia can be a type of pernicious anemia, because what pernicious anemias are results from vitamin B12 deficiency. Anyway, the other thing to remember about the folate is that, remember that the folate is important for purine and pyrimidine biosynthesis. So it's really important for making the nucleotides. And if you can't, well, the bases that will ultimately make the nucleotides. And if you can't make the nucleotides, then guess what? You can't divide. You can grow, but you can't divide. And that's where megaloblastic, big red blood cells come from. Vitamin B12, or the cobalamins, it's a group of cobalt-containing compounds that function in homocysteine metabolism and oxidation of long-chain fatty acids. And deficiency results in homocysteinurea, megaloblastic anemia, and neurological abnormalities. And again, one of the traps is that people will treat vitamin B12 deficiency with vitamin B9 and end up thinking that they treated it. But it turns out that treating the megaloblastic anemia by giving vitamin B9 folate it's not going to help with the neurological symptoms that result from the myelin being non-functional or dysfunctional. And then that's the summary that we're going to get. So we're going to move on then to minerals and wrap it up here. So minerals are divided into major and trace depending on the requirement. Again, minerals are just defined as compounds that our body needs. typically minerals will be some type of metal. Major minerals are required in amounts greater than 100 milligrams per day. Trace minerals are required in less than 100 milligrams per day. So minerals differ in their bioavailability, that is how much of X mineral will be actually absorbed once consumed. So some you'll have to take in a lot just because they don't get absorbed very easily, and others take in less. So here are some major mineral lab values. I'm really not going to go through these. You can just learn these as you go through your clinicals. But I will discuss a few things associated with sodium ion. Well, one thing associated with sodium ion, and the rest you're really going to cover probably when you cover the nervous system and excitable tissue, right? You've already seen magnesium ion. Magnesium ion plays a big role in many different protein and enzymatic reactions, particularly the DNA polymerases. Phosphorus, you already know what that's for. Calcium, you already know it's important for muscle contraction and cardiac action potentials, etc. And all right, so chloride ion, the big player when you get in the central nervous system, when you have a neurotransmitter trying to hyperpolarize the membrane, typically it'll be chloride going through that channel that the neurotransmitter opened. Anyway, I will talk about the sodium ion. Oh, and before I move on, I just want to mention this concentration, milliequivalent. So an equivalent is just quite literally what it says, an equivalent. So let's say you were looking at acids and bases, and you had an acid that was monoprotic, that is, it only gives up one proton. Then if you had 1 mole of that acid, then you would have also one equivalent of that acid. If you had a diprotic acid, that is an acid that can give up 2 protons, and it gave up all those protons completely. If you had 1 mole of that acid, you'd have 2 equivalents of that acid. Same concept applies here. If you have 1 mole of sodium ion, then you have 1 equivalent of sodium ion. If you had calcium ion, which actually has a +2 charge, and the equivalent that you're regarding is charge, you'd actually have, if you had 1 mole of calcium ion, you'd have 2 equivalents of calcium ion. I hope that makes sense. It wouldn't be new to you if you watched the acid-base lecture. Anyway, so let's say you had a sodium ion deficiency. What's going to result is called hyponatremia. Marathoners, so marathon runners, or people who do intense exercise and ecstasy are all common causes of hyponatremia. So it turns out that back in 2005, when some marathoners were running, they would just drop. They would suddenly drop, and they were taken to the hospital. And when they were taken to the hospital, the physician said, well, they were running. They were probably dehydrated. Let's give them some fluids. And it turns out when they gave them some fluids, they actually just got worse. They didn't get better. This was the case of hyponatremia. So what happened was that salt was lost through the sweat, and the increased water that people drink when they're marathon running dilutes plasma sodium even more, then causing low levels of plasma sodium. So now there's more sodium in the interstitial space, and that causes an osmotic pull of fluid from plasma into the interstitial space. And that results in swelling of the hands, feet, chest, and in extreme cases, cerebral edema, coma, and death. Again, it's probably not too clear to you why you only lose the sodium in the plasma, not necessarily in the extracellular fluid space. That's probably not clear, but it just is the case. And then the rest of it should make sense, right? Water goes where salt goes. There's more salt in the ECF, so you get edema, right? It also happens with people who are taking drugs and are at raves. They'll often drink a lot of water and get hyponatremic and become non-responsive. The other thing that's really important to really talk about here is just the fact that now clinicians know this and are aware of this and will not accidentally treat hyponatremia by giving more water. They will in fact give an electrolyte solution. And that's why at raves it's safer to be drinking Gatorade than water. Ecstasy had the property of making you sweat like crazy. Anyway, that's hyponatremia. That's all I have to say. Here the list of the trace minerals that's important. The numbers really are important here. Iron, a deficiency is common in children, menstruating women. Copper, it's called Wilson's disease, is a disorder of copper metabolism. Don't have much to say about that there. Iodide, we had a lot to say about that in the endocrine lecture. The deficiency causes hypothyroidism and goiter. As you know, the thyroid hormones T3 and T4 are called triiodothyronine and thyroxine, and they have a lot of iodide molecules. 3 for triiodothyronine and 4 for thyroxine. And obviously, so that if you have a deficiency, you're not going to get the T3 and T4, and you're going to get hypothyroidism. Fluoride prevents dental caries. So caries is just a fancy medical speak for cavities. And we'll finally finish up with this conversation about enteral and parenteral nutrition. Enteral nutrition is feeding through the GI system, excluding really the mouth. So you can call it tube feeding, but it doesn't necessarily have to be in a tube. It's just anywhere in the GI system that kind of just skips the mouth. And so you may hear the term gastrostomy, so that's just doing a little incision, typically in the epigastric area, which is that upper middle quadrant, if you would, the epigastric quadrant, and doing a little cut and suturing then a tube onto part of the GI tract, and then the food can get entered through that way, bypassing then maybe the stomach, or maybe parts of wherever you need it to go, really. And again, enteral nutrition, just feeding through the GI system, tube feeding. Okay, parenteral nutrition is different from enteral nutrition. It's actually injecting nutrients intravenously. So a solution containing simple nutrients like amino acids, sugars, and lipids will just be directly injected into blood. So again, you would do these kinds of administration of nutrients this way, either parenteral or enteral or parenteral, if for some reason the person can't eat, or they can't digest food, or some reason, or maybe they have an obstruction somewhere in the GI tract, so they can't really properly digest food, or it's dangerous for them to be loading up their GI system, then you would do this, right? And again, it doesn't have to be a needle, parenteral nutrition. Well, obviously there's going to be some needle involved, but it doesn't have to be a syringe. It can be, hanging from a bag. Either way, you get nutrients injected intravenously. The other thing that's really important to note here, that these are simple nutrients. They're not going to be polypeptides, because again, the way in which we digest polypeptide is through the stomach. Right through the stomach as well as within the duodenum. So these have to be simple nutrients that are already broken down. Note the trend. Enteral feeding is through the GI system. Parenteral feeding is through the vascular system. But both are ways of providing nutrition to a patient that is incapacitated in some way. And that is the end of the lecture. I hope you enjoyed it.